Good afternoon, everyone, and welcome to the second Health Equity Forum of 2022. I'm Rhonda Smith, the Executive Director of the California Black Health Network, and we thank everybody who is participating and attending the Health Equity Forum today. Before we get started, I just wanted to take a moment to honor and recognize an historic moment in history, and I think it's very apropos for what we are talking about today when we're dealing with or focusing on equity. And so I just got a news flash that Ketanji Jackson Brown has been confirmed as the first African-American female judge on the Supreme Court. So if not everyone is aware of it, just wanted to share that news and take a moment to enjoy this historic time for us in history and progress that's being made at the judicial level here in the US. So our session today is on historical racism and the impact on health disparities. And I'm super excited to have our speaker with us today. So we have Dr. Courtney Walker, Pharm.D. and researcher and medical account director at Novo Nordisk. We're very fortunate to have Dr. Walker with us today, and also the partnership and support of Novo Nordisk for our Health Equity Forum and a series of other things that we will be doing together in partnership this year. But before we start the program, I just wanted to go over a few housekeeping rules. So we'll hear from Dr. Walker first, who will share a short presentation. That will be followed by a conversation between Dr. Walker and myself on the historical racism and the impact on health disparities. After that, you'll have an opportunity to ask questions yourself of Dr. Walker. So if you think of questions along the way, please put them in the Q&A box, and let's reserve the chat box for conversations or engagement. If you want to give a shout out to people that you see who are present here today, you can do that, but just put all your questions in the Q&A box. And so before we get started and I introduce Dr. Walker, I would like to, for the benefit of those who may not be familiar with the California Black Health Network, and it may be your first time participating in one of our forums, I'd like to just give a brief overview of the California Black Health Network and what we do. So we were founded in 1978 and held our first statewide conference in 1980, and then expanded into more of a chapter and affiliate model across the state in about 5 different locations. We became a 501c3 in 1983, so come 2023, technically CBHN will be 40 years old. So we're looking forward to celebrating and honoring that milestone. We were also very instrumental in establishing and creating the Office of Multicultural Health, and also a co-founder of the California Pan-Ethnic Health Network, otherwise known as CPEN. So we have been known and are continuing to live up to the expectation of being the voice and trusted resource for Black health equity in California. And we are the only Black-led statewide organization that is dedicated to advocating for health equity for all African Americans and Black immigrants here in the state. So through that work, we envision and aspire to have a California where every African-American and Black immigrant has the opportunity to live long, healthy lives that's free from violence, racism, and health inequities. And we do that every day by working to ensure that all Black Californians, regardless of how well educated they are, how much money they make, where they live, who they love, their housing insecurity or immigration status, has the access to high quality, equitable primary and behavioral health care, and avoid unnecessarily succumbing to diseases, especially those that are preventable. And so I also want to share a campaign that we are currently involved in, and that's called the Campaign for Black Health Equity. By 2023, also in recognition of a significant milestone for us, our 40th birthday, our goal is to raise upwards of $2 million. So we have a very ambitious goal, and do our part to decrease or at least realize some measurable instances of a decrease in health disparities by 15%. A highly aspirational goal that we'll continue to work towards achieving beyond 2023. But we plan to go about doing that by a 3-pronged approach. And so we will continue to drive key policy changes throughout our advocacy and policy initiatives. We will enhance educational programs and offerings for both patients individuals, or all patients individuals, as well as healthcare professionals, and increase our brand visibility to become that respected thought leader that we are aspiring to be in the public health domain, as well as healthcare professionals and trusted resources for the Black community across California. And so there are 6 core elements of the Campaign for Black Health Equity. There's the Black Health Agenda, which is our statewide plan to address health disparities, which some of you on the call today may be familiar with the process that was in place a few years back. The Black Health Network, which is our community of community-based leaders and organizations, individuals, professionals who all work tirelessly every day to advance health equity for Black Californians. So it's a virtual community that you can join through our website. We also have the Health Equity Forum, which we are participating in today, and our Health for Life initiative, which is our series that aims to improve health literacy for Black Californians across the state. And we look at that from both sides of the patient and provider relationship. So we plan to work on both sides of that dynamic. And then our advocacy and policy initiatives that aim to improve access to quality, equitable healthcare, and really trying to drive change at the system level that is providing care to individuals across the state. And then last, we are a Covered California navigator. So we are certified to enroll individuals who are uninsured into healthcare plans offered through Covered California. And so without further ado, I'd like to introduce the guest of the hour, Dr. Courtney Walker from Novo Nordisk. Dr. Walker is a medical account director at Novo Nordisk, as I said before, for the Texas, Arizona, New Mexico, and Las Vegas region, specializing in diabetes and obesity. In his role, Dr. Walker spends his time consulting with healthcare plans and state government, mainly around Medicaid and Medicare, to really get drug formulary decisions made that can impact millions of patients throughout the country. In addition, Dr. Walker engages in large employers such as British Petroleum, Southwest Airlines, and the likes of those organizations to really focus on the clinical crisis of obesity and diabetes amongst their employees. He also aims to assist these companies to improve their employees' health via proper medical management. Dr. Walker has a wealth of experience and also has been a strong advocate for COVID-19. And focusing on the impact on patients with health disparities and who face various social determinants of health. Dr. Walker touts that he's a proud graduate of Texas Southern University's College of Pharmacy and Health Sciences in Houston. He's worked with many, many different healthcare companies and pharmaceutical companies in many different disease areas such as rheumatology, dermatology, gastroenterology, and oncology and autoimmune disorders. So I'd like to turn it over to Dr. Walker to share with us his presentation today. So Dr. Walker, take it away.
Thank you so very much. And thank you, Rhonda, for the invitation. It is an honor to be on today. I have extensive number of family members in the great and beautiful state of California. So again, it is indeed an honor. I'm going to go ahead and start my slides, and please let me know when they are visible.
We can see them, but not in slide mode.
Okay, I'm going to swap it over now. Okay, we should be good. Are we good?
We are good.
All right, so we're going to have a conversation today briefly on historical racism and the impact on health disparities, and talk a little bit about medical mistrust. And again, I'm very thankful for this opportunity to have this conversation with you guys on today. When we talk about medical mistrust, let's go back to the beginning. Let's go back to the beginning of some of the issues here that we've certainly seen. And we know that people in minority groups, specifically the African-American group in America, have many reasons to be distrustful. This history is filled with examples of exploitation at the hands of doctors and medical researchers. And what we know is in the 19th century, there was a Dr. Sims who made advancements in the field of gynecology by doing experimental surgery on enslaved Black women without their consent and without anesthesia. And if you think about that, not giving anesthesia, not giving pain medication, speaks to some of the issues that we're going to see later on in our talk, where we talk about there's still issues as it relates to African American women getting medical care and being able to get treatment that is comparable to other women in terms of the response to pain. And this goes all the way back to the 19th century. So certainly we'll talk about that. And then also the Tuskegee syphilis study, which I'm sure everyone has heard about. From 1932 to 1972, there were over 600 Black men in rural Alabama who were not told that they were that they knew that they had syphilis, but they weren't told, and they weren't given any medical treatment for their syphilis. So these men suffered for 40 years, and they were monitored and they were watched so that they were able to, it could be studied, the effects of syphilis long term. So really a guinea pig population. And then lastly, in 1951, the John Hopkins Hospital took cancer cells from a Black woman, Henrietta Lacks, without her knowledge or consent. They had been working for decades trying to find cells that grew in vitro so that they could do, or outside of the body, so that they could do medical research. And so lo and behold, a woman comes in, Henrietta Lacks, and happens to be that she has cancer. And those cells, her cells, actually grew outside of the body. And they took those and they used them in medical research, making billions of dollars in terms of impact years down the road. And so when you take in consideration of that, and you look at Dr. Janice Underwood, who basically says that the Henrietta Lacks story is not forgotten. It still has generational impact that's being spoken throughout the years. And we know Oprah Winfrey came out with the movie regarding Henrietta Lacks, and we're learning more and more about some of these atrocities. And these atrocities are based in systemic racism. We know that there's an intersection between social determinants of health and disparities by race and ethnicity, and it's rooted in this systemic racism that results in uneven access to quality schools, good paying jobs, higher incomes, wealth accumulation, better neighborhoods, health insurance, and quality medical care. And all of those are components of social determinants of health. And we know that COVID-19 really helped to expose that it's these individual factors that really work to determine health outcomes. And specifically in the African American population, there's significant impact. We know that there's clear and direct association between socioeconomic position and health outcomes. If you guys have seen, Oprah Winfrey has a new documentary coming out, and it's been advertised on the TV I think it's The Change of Color, or The Color of Change, and just talking about the impact of health, the color of care, and having to talk a little bit about the impact of socioeconomics and its effect on health. And so this is a greater conversation that we're now having. We know the educational attainment, household income, residential environment, access to healthcare help to explain more of the disparities in obesity and cardiovascular disease. And we know that African Americans, along with Latinos, American Indians, Alaska Native population, are going to be more susceptible and are more likely to have lower high school graduation rates, individual and household incomes below the federal poverty level, and lack of insurance. And all of these things stem from systemic racism that certainly extends over time. And so that is going to be also a part of our conversation. And when you dig deeper into the African American story in regarding to this, one of I know everyone probably is familiar with Nicole Hannah Jones, the 1619 Project. She has a quote in the book that really hit me, and she says, she talks about, you're talking about 250 years of slavery for African Americans in the United States, and you're talking about since the Civil Rights Act was written in 1965. The African Americans really being free for about 50 years. So you're talking about a significant time, 5 times longer African Americans being in slavery than being free, and you're expecting things to be equitable, and certainly they are not. So when you look down at the bottom, it says increased burden of health outcomes from obesity, cardiovascular disease. And when we talk about obesity really stems out to about 200 other diseases. We know that once a person is obese, they can have insulin resistance, leading to type 2 diabetes, leading to other diseases, the increased weight causing joint problems or causing cardiovascular problems. But when you look here, think about toxic stress, the effects of some of those negative factors that we talked about, and having no outlet, having no support, no help through that, and that comes out in health outcomes, increased cardiovascular disease, stroke risk factors, all of that stemming from some of the things we talked about: poor access to capital, poor access to healthcare, housing conditions being poor, physical environment, poorly funded schools. You think about housing conditions, think about, in the 1930s and 40s and 50s, the project systems where African Americans were put up, high in Chicago, city of Chicago, Cabrini Greens, and not given resources. What was the overall impact of that, right? And so then going back to wealth, poverty, and social determinants of health, factoring into that, it could be through the justice system, which is disproportionately minority involved, African Americans being a huge part of that. And then going back to, let's talk about it, Jim Crow laws, segregation, redlining, targeting African Americans, post-emancipation structures of racism to maintain white privilege, and then white supremacy through structures of racism to maintain that, and then ultimately back to slavery. So when you think about that, that really gives you an opportunity to really understand some of the issues in the African American community and why there's such a suffering when it comes to poor health outcomes. And so what are some of the examples of this? Well, we know in African American women, Serena Williams' postpartum complications, and the story of Shalon Irving, who was actually an epidemiologist at the Centers for Disease Control and Prevention, who studied racial disparities in healthcare. She died 3 weeks after giving birth from complications of high blood pressure. And it's really focused attention on racial disparities and maternal mortality and morbidity. African American mothers die from pregnancy-related complications at 3 to 4 times the rate of white women. And while maternal mortality has been dropping in sub-Saharan Africa, rates actually increased in the United States from 2000 to 2014 with African American women. We know the socioeconomic status, education, other factors do not appear to protect African American women from this risk, while factors including smoking, drug abuse, and obesity do not explain the differences. And then you look here, an African American woman is 22% more likely to die from heart disease than a white woman, 71% more likely to die from cervical cancer, and 243% more likely to die from pregnancy or childbirth related causes. So it's a significant issue that we have to think about. And so this all goes back to the conversation on health equity, social determinants of health, and health disparities. We know the goal is health equity, right? We're hearing that word ever since COVID. That word has become, we have departments of health equity that have started in health plans and in health systems. Health equity, what does it mean? That means removing all barriers so that everyone gets an equal opportunity to achieve their full health potential. As you can see in the diagram below, you have all the equality is everybody's at the playing field, but equity is when everyone gets to see the field equally. And so that's the goal of where we certainly want to get to. And the approach is through really having that conversation, the honest conversation on some of those social determinants of health, those conditions in the places where people live, they learn, they work, and they play that affect a wide range of health and quality of life risks and outcomes. And that can be through access to quality health care, discrimination, education, employment, food security issues, income, safe housing, social support, and then also digital health literacy as well. And then when you think about a metric standpoint, you're getting into health disparity, right? And health disparity is really about exploring what are the health outcomes. Are we seeing diabetes getting better or getting worse? And then when we break down in the individual racial groups that are impacted, what is happening over certain periods of time? And so certainly in the African American group, we have to take those things into consideration. So our goal is health equity. We're going to approach it through social determinants of health and impacting those individual factors, and then hopefully seeing health disparity improve. So why is this important? It's because it's all about, number one, the individual, right? The individual, when you think about a socio-ecological framework, this really should be used to guide the prevention of childhood obesity and other diseases, right? Because any individual is based on four other elements to help to make up that person. So number one, they have their interpersonal, their family, the values, their culture, how that's encouraged, encouraging their individual identity. Then organizational, community organizations, their faith organizations, their schools, and then the community, from their health care, from neighborhood, parks and recreation, the people they hang out with, the influence of the food industry. That's all a part of the community. Again, all of these things leading down to the individual. And then ultimately, from a public policy standpoint, that's where you have the impact of laws and regulations and government, and how that then also then builds the final layer to who that person is. And so that's why it's so very important for us to evaluate what are some of the things that have affected individuals leading to some of these outcomes. We know in every city that there are zip codes where there are higher rates of disease, there are higher rates of diabetes, higher rates of high blood pressure, higher rates of cancer. And why? Why is that? So that is why it's so very important to take that look at the individual and see if any of these, what a part of those components are working to influence the health of those individuals. So this was a New England Journal of Medicine study that was actually done March of 2021, and this was 550 completed surveys, and this was by the Insights Council. This was a group of executives and clinical leaders and clinicians that were really involved in care delivery. And they were asked this question: what programs and commitments has your organization made to address disparities in care delivery? And the top two things were organizational commitment to advancing health equity. So what we know right now is health equity, removing those barriers, is a part of everyone's language now. I'm hearing it from health systems to employers to health plans, PBMs. Everybody is having to think about health equity. And why is that? Because what we saw with COVID-19 is that those who were disproportionately affected, minority populations, those who suffered from obesity, those with type 2 diabetes, those with cardiovascular disease, they had more of the negative health outcomes. And because of that, everyone now has realized, listen, we've got to start to build up, in a sense, the least of these to help them to be as healthy as possible. So organizational commitment to that, number one. Two, interpreter services, right? So speaking the language of those whom we serve, or those who are a part of our organizations, that is going to be a huge part of it. Hopefully, we'll be able to talk in the future about some of the research that's been done. There's been studies done in the Hispanic population to help to improve obesity. And when they spoke the language of the culture, when they tried to create diets associated that were more connected to their Latin background, the women got healthier. Same thing in the African American population. There have been studies that have been done where they really did a focus on creating diets and menus and foods to address the ladies based on their culture, where they came from, and it really hit home. And so speaking the language of those you're talking to is so very important. Community outreach, increase access to care. Again, those social determinants of health being addressed, developing systems measuring race, ethnicity, language, and patient residence, community partner engagement programs, social care providers is integral to teams, healthcare teams, and community health needs assessment screening. That's the first part. Knowing your environment, knowing the individuals that you're serving, what some of the needs are. What are some of those specific social determinants of health? You got a list of them. Is it a food security issue, or is it a transportation issue? Is it a social support issue? What is the need? Is it a health literacy issue? Programs to identify social needs, most effective ways to assess and document those needs. So that's important as well. And then when you get to the individual, motivational interviewing, right? And so that's going to be a counseling approach designed to help people find the motivation to make positive behavior change, okay? And so what we know, it's been shown to improve medication adherence among minority groups, such as those who receive treatment for HIV. We know that in addition, it's and then cardiovascular disease and schizophrenia. So those diseases respond better to those who do motivational interviewing, and really successful motivational interviewing consists of engaging, focusing, evoking, and planning. A four-tier method where you want to engage with the individuals you're talking to, you want to focus on their individual needs and help them to focus, evoke change within the counseling, and then the planning, helping them to plan in the future to maintain some of the things that they've learned, but really to give them, to motivate them, to encourage them towards positive behavior change, okay? And what we know is that poor medication adherence is a significant problem in African Americans with hypertension, but a lot of it has to do with being able to connect with the African American population. One of my passions is to sit down and have a conversation to help patients understand the disease state. So I'll give you an example. Diabetes, for an example, is a disease that certainly plagues within the African American population. I grew up in Arkansas. My grandmother called it sugar. Sugar diabetes. She didn't have it, but my grandfather had it, right? And everybody knew somebody in the community. And I'm sure certain ones of you listening have heard the term, baby, I got that sugar, okay? And the problem with sugar is also a term of endearment that you call a loved one, right? So, hey, sugar, how are you doing, sugar, right? So sometimes it's hard to take seriously a disease that you also use as a term of endearment. But when you sit down and teach and have the conversation and say, hey, the reason diabetes is bad is because excess sugar sits in the bloodstream. And over time, that excess sugar leads to oxidation, and oxidation affects the blood vessels in a way where it causes oxidation and leads. And oxidation is the same process of the over ripening of a banana, where a banana gets brown. Well, that's oxidation. That's accelerated aging. And what happens to an over ripened banana? If I squeeze it, it breaks easily, right? Or the rusting of a car, that's also oxidation, right? And when I touch a rusted portion of the car, it breaks easier. Well, that's the same thing that happens in blood vessels that are affected by type 2 diabetes that's out of control over a long period of time. And where does it happen first? In the smaller blood vessels. It happens in the kidneys first, because those are smaller ones, and then the eyes first. That's why diabetes is one of the leading causes for end-stage renal disease in the kidneys, and one of the leading causes for blindness, right? And that's the microvascular complications. And when you have an A1C over a certain number 7, you're more likely to have that type of problem. And then ultimately it can lead to macrovascular or large blood vessel problems in the same principle, that excess sugar over time leading to that problem where you have that rusting of a car effect, or the over ripening of a banana, where those blood vessels break easier and leads to amputations in the nerves, because it causes the nerves to dysfunction, and then in the cardiovascular system leading to stroke, leading to heart attacks as well. So that's just a way in which having those conversations to help in the understanding, and making sure that patients understand the disease, and meeting them where they are. Acknowledging sugar is certainly a way in which they heard it, but do you really understand the disease? And so taking the time to have those conversations with minority groups, especially African Americans, can help pull us out of the doldrums of some of these negative health effects. And lastly, when we talk about an integrated approach, the integrated approach is going to be of a huge assistance, because it's going to incorporate everyone, right? It's going to incorporate the individual who's suffering with obesity. Here are the statistics. In the United States, we are 42, when COVID started, we're at 42% obesity. 42% of the United States, compared to 6% in China, 10% in Italy. That just gives you a comparison, right? It has been thought that since COVID and quarantining, we've gone up by 3 to 4%. So we're probably about 44, 45%. The African American population, adult African Americans, we are about 49%. 49% of adult African Americans are obese, and 50% of African American women are going to be obese. So more of our women suffer from obesity as well. So when you think about that, then obesity being a precursor to type 2 diabetes and almost 199 other diseases, because there's 200 other diseases that obesity is the gateway for, that certainly speaks to the need to take seriously obesity management. And so we want to think about the integrated approach to managing that. That's where we take the individual who suffers with that, their community, their family, their caregivers, helping them to understand where they are, and then involving the system, the clinical system, which consists of the doctors, the nurses, the pharmacists, the psychologists, the health coaches, and then the community. That's the community planners, the employers, the payers, the providers, the policymakers, all of them to support the individual. And when we've had programs that did that well, we saw 6.4% mean weight loss at baseline in a year. We saw that 50% of those individuals maintain that with a 5% weight loss over the next year. And we know that just a 5% reduction of weight can lead to reduction in likelihood of going into type 2 diabetes, reduction in likelihood of going into arthritis. And we know that all of that can take place due to having that support system. So when we think about the impact of what we've been talking about, the goal is to help our community with motivational interviewing, with an integrated approach to management, and obesity is example here, but it could be diabetes, it could be high blood pressure, it could be cancer, it could be any of these diseases that certainly have over a period of time ravaged our community and caused really negative health effects. And here you see the benefit is reduction in blood pressure, in A1C, which is a 3-month measure of your blood sugar levels. It can lead to increased fruit and vegetable intake, increased physical activity, and improved quality of life. So this is why this is so very, very important that we have this conversation, and we take seriously our past, but we start to build bridges regarding having a more healthier future. So Rhonda, I'm gonna turn it over to you, and I know we have some questions that we're gonna go through, but this was just a brief overview to kind of lead us into our conversation.
So thank you, Dr. Walker, very much for sharing all of that information. And yes, I do have some questions, and I want to remind the audience that you also have an opportunity to ask some questions. So I don't see any questions in the Q&A box yet. See lots of activity in the chat, so thank you for all your comments. And yes, Dr. Walker does appreciate your comments about the content that he shared. So I'm going to try to unpack a lot of what you said, because there was a lot. And so I guess maybe the best way to start is by acknowledging the fact that we know that, just if you look at the data, right, the US healthcare system is kind of already broken, right? You talked about some of the statistics and the data. We know that the US spends the most money on healthcare in general and per capita. We know that at birth, we have the worst outcomes compared to most other developed countries. And I'll get to Black maternal health in a minute. And so with all of that, you talked about motivational interviewing, right? And a little bit about what that is. But I want to talk about, how do we improve health outcomes using that? And why are we not using that more in terms of how healthcare is delivered? Because it sounds like through motivational interviewing, there's an opportunity for the patient and the provider to really develop a relationship and have more dialogue about what's really happening with that individual patient. So it's really more of a one-to-one, as opposed to spending 5 or 7 minutes, with the doctor in an office-based visit. So can you talk a little bit more, Courtney, about what role you think motivational interviewing can play in helping to improve health outcomes?
Absolutely. I think it's extremely important. Again, from a definition perspective, it's a counseling approach that's designed to help people find the motivation to make positive behavior change. And being a pharmacist, I go all the way back to the early 1990s. And when patients came into the pharmacies, it really wasn't a huge focus on counseling patients at that time to help them understand their medications, how to take them, drug-drug interactions. We asked if you had any questions, but it really wasn't about counseling, right? So now, as the years progressed, it was all about counseling and making sure and now if you go get your prescription, you have to be counseled on your medications, right? So but across the board, it's about spending the time to have the conversation with patients to make sure that they understand, so they're motivated to change. If they don't understand the disease, then how are they likely going to really change the behaviors to bring about healthier outcomes, right? If you don't understand how I described diabetes earlier in a way where it's like, oh, the light bulb goes off and you get it, and you're like, oh, I don't want excess blood sugar in my bloodstream. So, oh, exercise can help that. Oh, medication certainly can help that. There's certain things you can do on your own, but then there's certain things that a doctor, a pharmacist, a physical therapist has to counsel you on, where you can do it yourself. So I don't think it's being used because it takes time. It takes a lot of time. You have to have physicians certainly who are committed to it. As the company I work for, Novo Nordisk, we have diabetes educators. They specialize in counseling on motivational interviewing. That's actually not a part of what I do per se, but our diabetes educators, they help doctors' offices, they help diabetes education centers, and they go in and they counsel on motivational interviewing to help patients be as equipped as possible so that they can be successful in turning their diseases around. And in the African American community, we have to do more across the board to help our people understand, okay, it's not completely your fault that you're in a situation if you have genetics that predispose you. I have a good friend that he's 60 years old and it just not hit him high blood pressure. He's been away from it for years, but it finally hit him, and he knew it was a part of his lineage. And he gave me a call and he said, "Hey man, can you help me understand this?" They're trying to put me on medication, and so we had a motivational interviewing session. And so I think clinicians need to be committed to motivational interviewing techniques to help, again, number one, engage, number two, focus, help in focusing, evoking a response, and then planning, where they make it a part of their life so they move forward with those behaviors to be as healthy as possible.
Thank you for that. And so I think the important thing that I heard you say is, like, at least kind of what I think I heard you said is, this is a good way to focus on prevention, right? By engaging in this kind of dynamic and conversation between a patient and a provider. It's a way to focus a bit more on prevention. So when you talk about diabetes and obesity and some of that, yes, is genetic, but some of that relate to factors that we can't control. So if we know that the majority of the healthcare costs, right, are related to chronic diseases, and the majority of chronic diseases are preventable, then why are we not doing more of that to deal with all of those issues, right? So do you have any insight? I know that's like the $64 million question, right? But do you have any insight about that?
Well, I mean, the thing about chronic disease is it's a vicious cycle. I mean, it is a costly system. I mean, there's a lot of money certainly being made from disease, so prevention certainly has to be more part of the conversation, and you have to catch patients early. So it's really important that we catch patients as early as possible and be a part of prevention and turn it around. We're actually more and more looking at our medications and looking at how those medications are helping people get to what's called normal glycemia, or normal blood sugar levels, right? Or healthier weights, getting people back to the place where they're most healthy. And so that's a process, and why have we not done it? I think that we really haven't understood the ramifications, especially in the African American community, of some of the things that we talked about for medical mistrust. Medical mistrust leads to not paying attention, not being aware. One of our patient ambassadors at Novo Nordisk is Reverend Run, and I was very fortunate to be a part of the Congressional Black Caucus with Reverend Run, and one of the things that he focuses as an ambassador with Novo Nordisk is on awareness, and he does a phenomenal job of talking about raising the awareness. So he said when he gets with his friends, he says, "Hey, do you know your numbers? Do you know your body mass index? Do you know your blood sugar level? Do you know your blood pressure? Do you know your blood panel?" He asks his friends that, how often have we done that in our communities where we talked about awareness? Because ultimately, motivational interviewing should help patient adherence or medication adherence get improved, or being adherent to healthy eating habits, which then in turn don't lead to some of the negative health conditions. Rhonda, I shared with you, my wife and I, our son is a baseball player, and we go all over the city. Some of the neighborhoods, there are no healthy food options. It's all fried. So we have to take lunches to some of those places that we go to, and being aware of certain areas. And that's the level of awareness that we have to do ourselves to help ourselves be as healthy as possible moving forward. So it's a huge part of our responsibility to be aware of our genetic history and predisposition to disease, because ultimately our ancestors, I mean, we have to be very honest, there wasn't a lot of fruit and vegetables per se. They did the best they could with what they had, but a lot of the scraps, as it were, led to the fact that from a genetic standpoint, we have to be really on top, because there were some negative choices that were made, not to no fault of their own, that have led us to where we are genetically right now.
Right. And so you kind of touched upon something like generational, right? And so in your talk, you also talked about, toxic stress being
Yes.
part of kind of impacting our health and well-being and health outcomes. So are you able to talk about the generational trauma, right? Going back to the slavery days that you mentioned earlier, and how that's also had an impact on our health and well-being, in addition to our nutrition history and what we didn't necessarily have control or many choices over, from generations ago.
Yeah, I think it's hugely important. And that's why I love, again, I mentioned the Nicole Hannah-Jones, the 1619 Project. And I love the conversations that we have more so about understanding our history. And I'm a context person. I believe in order to understand where we are right now, you have to understand the past. And so when you understand that slavery was extremely stressful, as it were, in terms of, the lack of resources, the work, and the genetic gifting that it gave to us, there were some positive things, but there were some negative things as well. And so the impact of that, I think we still are understanding. From a Jim Crow perspective, I think is even more impactful when you talk about as the slide stated, white supremacy and some of the white privilege things, and then how that affected the African American population. And although we've had some wonderful success stories of families that have persevered and succeeded even in the midst of those challenges, you've had a vast majority of those who have struggled and have significant challenges. And so in light of that, it's all about education. One of the reasons I wanted to be a pharmacist was I watched my grandfather give himself the back in the 70s, those ampules. He had to break the insulin container, and he had that long harpoon needle and gave himself an injection for type 2 diabetes. And that was I watched him do that, right? And a lot of that, and he had my grandfather had a beautiful big belly, but that was visceral fat. I thought it was fun to sit up on grandpa's belly, but now I understand that was visceral fat that is more of a predisposition for cardiovascular disease. And unfortunately, he ultimately died of a heart attack in 1983, which we know was probably led by being obese and having type 2 diabetes. So those are the honest conversations that we have to have about the impact of, number one, genetic predisposition, bad foods, work habits that were very intense that led to shorter life expectancies. And what was that effect now on future generations? And so as we move forward, that toxic stress, that's a part of social support, right? So now we look at one of the social determinants of health components is social support. How can we provide provide social support in such a way where we undergird families, individuals, communities, and help them feel supported so that they can do everything at their disposal to get to be as healthy as possible. And it's not about a handout, but a hand up. How can we help everyone have the potential to be as healthy as possible? But I think we do have to be very honest about our background, where we came from, so that when we move forward, we can move forward being healthier and then teaching future generations how to maintain that health and well-being.
Yeah. Thank you. So I see we have a few questions in the Q&A box, but I wanted to bring something out before I open up to the audience questions. And so you talked about some instances or cases where there was racism and discrimination that led to poor outcomes in Black maternal health situations. And next week is actual Black Maternal Health Week. And so I wanted to uplift that a bit and also kind of reflect on the conversation that I had this morning with some other folks about a situation where there was a Black woman who was giving birth, right? And she's a senior executive at BET who kind of dressed down to give birth. And then the horrible experience that she had when she was about to have her baby. And thanks to a doula being present, that doula was able to intercept all of that and get that team changed who was actually in the delivery room with that woman. And then on the other side of that, when she got dressed up again in her professional attire, she actually went to talk to the administration at the hospital where she gave birth and was able to drive change. But not everybody has the opportunity to do that. And we know that race obviously played a role in that, because no matter how well educated she was or is, and how much money she made or what kind of job she had, when she dressed down and presented as a Black woman, she was treated in a certain way because of the perception that the healthcare providers had in that situation. So what are your thoughts about what we can do to address some of those issues? Because you even talked about Serena Williams and the experience that she had. We know Tatiana Ali, the actress from The Fresh Prince, also had an unpleasant experience when she gave birth. So interested in hearing your thoughts about that.
Was as a father of 4 beautiful children, and to watch my wife go through that process 4 times, I now realize it was a miracle. It was a miracle each time we were blessed to give birth to a healthy child. And certainly, in every woman, especially African American, when you look at these numbers, 243% more likely to die from pregnancy or childbirth related causes, and African American women die 3 to 4 times the rate of white women. It's a serious issue. So I think we have to be very honest. The scary thing about Serena Williams, Rhonda, I'll point out, is that she knew her history for developing blood clots, and she felt uncomfortable. She had chest pains during her delivery, and she didn't feel right after she delivered, and she talked to the doctors and they ignored her. And I think they ignored her pain, they ignored her discomfort. And I think that goes back to Dr. Sims in 19th century, who did experiments on Black women where they didn't give anesthesia. They didn't respond. It was just experimental. They treated Black women as almost, just experimental guinea pigs, unfortunately, in terms of terminology. But I think that same type of attitude is still present, and we have to do everything that we can to eradicate that mentality when it comes to an African-American woman's pain and what she says she's experiencing and what she's going through, to bring about that change, because these numbers should not be what they are. When an African-American woman gives a complaint, it should be heard, it should be responded to seriously, because if it weren't for Serena Williams really understanding her own body and her own story, she probably would have died. Most women in that situation, she had a clot, she would have gone to a pulmonary embolism, and she would have died, and it would have been a horrific situation. And so what I think has to happen is advocate for yourself. Speak to the women, to the African American women, to be their own advocates, know their own health history, know their story. If you don't feel right, speak about it early. Talk about it. Talk to your doctor. Talk to your doula. Have a support system. We employed a doula for. We had a difficult pregnancy with our second child, and we employed a doula. and she was phenomenal. She helped tremendously. And for that particular childbirth, we needed that extra assistance, and she was an extra eyes, she was an extra set of ears, and she helped in that process of getting healthy delivery. In terms of our baby girl. So, advocate for yourself, communicate, and raise awareness. If you know of a story, make sure it's heard about and known about, and continue to have those conversations with our medical professionals, who I really believe are trying to do a great job. But we just need to be aware of these statistics and these numbers, because numbers don't lie. It's one of those situations. Numbers do not lie. 243% more likely to die from pregnancy and childbirth. That should not be the case. And so we have to do everything we can to turn that around.
Okay. Thank you, Courtney. So I want to start to pose a few questions to you from the audience. And so Rochelle Thomas Self wants to know, are you aware of any program for reducing the weight of Black women, which also has helped them to retain, retain the weight loss based on, one of your slides that you presented?
Well, we don't have a Black women specific program. We just have a new drug that just came out called Wegovy, semaglutide 2.4 milligrams, and 15 to 17% reduction of weight from an anti-obesity medication perspective, which is the highest in terms of any medicational way in which to lose weight. When you compare that to lifestyle management, which is diet and exercise, gives you about 3 to 5% reduction, 6% at the absolute most. And then when you talk about surgical intervention, you have gastric sleeve, gastric bypass. That's going to start at about 16% reduction, and it can go up to 32% reduction, right? But with that, when you have surgery, there's a risk of subsequent surgeries after that to fix whatever was not done correctly. Anti-obesity medications can really bridge the gap between the two and give you significant reduction. So the current drug is 15 to 17% reduction. So that certainly can help from a medicinal perspective. I am aware of now more studies that are being published that are speaking to the specific issues of minority health improvement, and specifically obesity. We have a study that's in process right now. It's being reviewed. Dr. Ramick, who was a part of the pact of three African-American young men who made a pact to be doctors. He's actually one of the authors of the study, and it really looks at the African-American population and obesity management. So hopefully there will be more programs like that comes out, and we will have some focused on helping African-American women lose the weight and then maintaining that weight loss. Because unfortunately, as I mentioned, of that 49% of African-Americans who have obesity in the United States, 55% of it is African-American women. And certainly that's a predisposition to some of the other diseases we mentioned: diabetes, cardiovascular disease. And then you mentioned weight regain. You want to get the weight down and then maintain lifestyle management. It's not about just the solution being in the medication, but lifestyle management being a part of it, where you get healthy, dietary and exercise habits to help maintain that weight loss.
Great. So you kind of touched upon this a little bit, but the question is, how does our community determine which clinical trials will be beneficial for us versus what Big Pharma wants to do, right? And I thought that was an important question, even though that wasn't the topic of today, but I know there's a lot of misinformation, misunderstanding, distrust when it comes to participating in clinical trials, which, as you know, and we know, can also play a role in decreasing health disparities. So can you talk about that a little bit?
Yeah, well, one of the things that I have to mention is that we are not participating in clinical trials the way we should. There are statistics that show that we are underrepresented in clinical trials, and there's a few reasons. Number one, we don't seek out clinical trials and a large percentage of us, and then we're not being recruited for those clinical trials. So for example, I worked for a company that had a drug, and I was working in oncology and prostate cancer specifically. Well, we know that a large percentage of the patient population with prostate cancer are African American men, but every study that was published, that was done while I was there, 97% white male, 97%, every study. And it was so frustrating. But again, the white men were very aggressive to be a part of these clinical trials. So when you think about clinical trials cost a lot of money. So the reasons why big pharma is a part of running those trials is because they have the resources to actually execute the trial. They have the access to medication, the resources to get the physician groups together. So that's a huge component of it. So underrepresentation, from the patients pursuing the clinical trial to be a part of, and then not being recruited. So we have to make solutions there. I will mention the All of Us Research Initiative from the National Institutes of Health. I've been a huge part of that. It is a focus of getting up to 1 million individuals to be a part of research initiative that's sponsored by NIH, and its sole purpose is to improve African American participate in research. And so the All of Us Research Initiative, I think it's up to 400,000 in terms of those. So they're 600,000 away from their goal of 1 million. So that research project is a good start. But I would tell you, when you know a family member is suffering from maybe a rare condition, there are clinical trials. Type it up. Find out, make the decision as a family if being a part of that trial is something that you guys would like to do or not to do. But it really takes, you are a part of that. That's not just, you have a lot of autonomy when it comes to being a part of clinical trials. And I certainly encourage everyone to encourage family members and friends to pursue that information to be a part of it.
Great. So there's a few more questions that I want to get to before we end today. One was a question about what we can do to really educate our Black children around prevention and wellness. And is there some sort of program or curriculum that you're aware of that can be used for the community?
Yeah, one of the things that Novo does, we have social determinants of health. We have initiatives with the Boys Club, the YMCA, organizations where you're really trying to stress health and wellness and proper eating and drinking. So I think that's really, really important. It's so funny. I remember as a kid, I'm kind of dating myself here, Rhonda, but you remember that you are what you eat from your head down to your feet. The commercials that came down that used to come on TV, the Schoolhouse Rock, and some of them that were focused on food and eating. And I really think that, I know it's funny, but I think that we have to continue to have those conversations, the food groups, and understanding the need, the benefits and the harm of too much carbohydrates. Carbohydrates are not totally the devil, but too much of them can certainly predispose you to be heavier, or proteins, and understanding fruits and vegetables and the value, and really just the need to be very wise when it comes to sugar intake. I think that we have to start earlier, because a lot of the whole concept, and this was from when we were kids, you are what you eat, and you are the kinds of foods and the amounts of certain types of foods that you eat and intake as well. The benefits of water, staying on my son who's an athlete, it's not Gatorade and Powerade all the time, but sometimes it's water, and the benefits of flushing your system and getting some of those toxins out. So I think we have to continue to do a better job ourselves of stressing and sharing that information. And in communities where that need support, I'm thankful for organizations such as Novo Nordisk and other companies who are doing what they can at YMCAs and community health rec centers to help kids be educated. And then also, some of our wellness centers that are in inner city communities are trying to do that as well. We're seeing programs now that's called prescription food services, where they're teaching families how to cook, how to prepare fruits and vegetables, how to prepare eggplant, how to prepare squash, how to prepare zucchini. There's so many families that, I'll give you an example, Rhonda. There was a center down in Houston, and what they did was they would give families boxes of fruits and vegetables. Well, they actually found some of those boxes thrown away with all the vegetables and fruit still in it. And it was because nobody had taught the families how to prepare them. So what they did was they brought a chef, and when they gave the box, they had a presentation to show, this is how you prepare squash, this is how you prepare zucchini, and here are the health benefits. And then they did flavoring, and certainly, Rhonda, you guys are committed, because we had a wonderful food session last year. I'm going to have another one this year at some point this year. And but that's a part of it, education and teaching, and that goes back to the motivational interviewing. If we educate and teach, then we kind of help people move towards being healthier in some of their habits. So, and that helps kids definitely.
Great. So one of the questions, there are lots of questions left, and I want to be respectful of everybody's time too, but it relates to like more awareness and action along the line of health policy change. And I know you've been involved in some of that. So wanted to get your opinion about what can be done on the health policy side of things to really help improve outcomes and address the disparities issue.
I think that's huge. And I think that's a phenomenal question. Health policy has everything to do with overarching impact on some of the issues that we have. And number one, I would say your advocacy groups are going to be huge, especially when it comes to certain disease states. So certain diseases, so if it's obesity or diabetes, the groups that advocate for those, and then not even getting to, and then just prevention, being preventative care, there are advocacy groups that focus on that as well. So it's really important from a policy standpoint to understand where your Congress people, where they stand on certain diseases or on certain policies, on food nutrition, on food security issues, helping our neighborhoods be as healthy as possible. So I think that's huge. Understanding some of the laws and health policy and what you can do. And then also understanding organizations that provide um, 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 food services for those who are suffering, who need help and assistance. There are some that, hey, I believe in the widows and the orphans. There are a subset of our population that will need help. And in that, health policy helps in that. Sometimes there's a negative connotation when it comes to welfare or assistance, but that's desperately needed when you have communities that desperately need that assistance and that care, because we have a starvation problem. So because of the starvation problem, we need assistance. So that's a part of it as well. So if there's an issue or that you're passionate about, I would definitely look up who your congressperson is, who your senator is, understand their position on that, understand that your letters matter, understand that when there's open forums for you to go share what your feelings are, that matters as well. Being connected to the California Black Health Network and their position on policy, on public policy, and some of the things. I think Rhonda's done a phenomenal job, if you saw the description earlier, of what the passion of the organization really is about. That's what we're talking about. So raise your own awareness to be aware of what public policy is, if it relates to disease, if it relates to just the African American or Hispanic or the American Indian elderly population. It could be elderly. I have a colleague that works with Stanford University, and he has a huge passion on the elderly population, the Asian population up there as well. So there's much that can be done. But it really is going to take you to get out there and be active in that.
Well, thank you, Courtney, for saying that and for giving us a shout out. But just wanted to say, if you have any final words, especially as it relates to the topic today around racism and the role that it's played in health disparities, I'd like to give you a minute just to put a ribbon on it and wrap things up, and then we can conclude for today.
One of the things that, talking about Henrietta Lacks, there was a bill in 2019 that President Trump did sign. And one of the few of the things that it did was it talked about informed consent, medical records, privacy, communication with tissue donors and research participants. All of those things are in place now. In addition to that, you have institutional review boards, a part of universities. So that really, I was a part of institutional review boards, and before we do a clinical trial, we have to make sure that it's fair, that it's just, that there's informed consent to everything that we were going to do and that we attempted to do, and that's just so very, very important. And I think, I would like to say that there have been strides that have been made, and to just be aware of those things, be aware that it's not what it was. I know that there was a lot of concern about the vaccines. There was a lot of concern about research, period. There's a lot of fear and a lot of trepidation, and rightfully so. One of the things I wanted to say is, it's validated that there are concerns there, but we certainly have made strides. And so hopefully we can move towards medical mistrust to trusting more. Another thing, Rhonda, that I didn't mention too is, and we need more minority representation in the medical field. We need more African-American doctors, more African-American nurses and pharmacists and medical professionals. I want us to continue to encourage our children, the next generation, to go to medical school, to go and be these clinicians, so they improve the numbers and representation. One of the things I studied was a lot of cultures, especially the Indian population, from not American Indian, but those from India. We know 25 to 30% of our physicians are Indian, right? And they constantly encourage each other to go into the medical field. And I think we need to do the same thing in the African American community, encourage our young people to pursue medicine, to be a part of the solution in the future. And so I think that's what will turn around medical mistrust, because we have more clinicians who care and who can relate to our story and our background, we can do more help in the future to turn things around.
Great. So thank you, Courtney, very much. I want to point out that we will be bringing Jerry Lacks and her brother David Lacks back for a session kind of to talk about the Henrietta Lacks bill and clinical trials and all the things that the family has done actually to put in and ensure that there are safeguards around clinical trial participation, especially for people of color. And then also the fact that the family does play a role in decision-making about what happens to the HeLa cells or to Henrietta Lacks' cells in medical research today. So everybody who's listening, be on the lookout for that to happen in the next couple of months. And with that, I want to thank Dr. Walker again for being with us today and for the support of Novo Nordisk and being such a great partner, and everyone behind the scenes who helped get things together and on point for today. And just wanted to remind everyone and thank you, Danielle, for putting it in the chat, that you can follow us and keep up with what's happening with CBHN. You can go to our website at cablackhealthnetwork.org. You can follow us on social. It's really easy. Everything is your CBHN. So thank you all for attending today. Hope you enjoyed the information and you were able to take away some important nuggets or information that maybe you weren't aware of before. If you have any questions or want to follow up with us, you can please email us at info@cablackhealthnetwork.org. So thanks, everybody, and have a great afternoon.